Welcome to the management of AKI. Okay, so initially you want to establish, is the patient being managed outpatient or inpatient, and so you need to know which are those patients that you need to treat as an inpatient, or you need to refer the patient immediately. Okay, so as I'm displaying there, any patient with stage 2 or stage 3 AKI, according to the KDIGO criteria, should be immediately referred. Okay, any patient that is in the emergency department but you lack the reasonable certainty regarding the cause or the course of how the disease plays out, you need to make sure that the patient is referred. And finally, number 3, if you are in a resource limited setting, okay, where your initial diagnostic evaluation, whether you're doing now in ultrasound to rule out UT obstruction, or your interventions like IV fluids are not so readily available, you need to refer the patient for departmental referral. Okay, now it's always useful before you start with the full management of the AKI to understand which patients you need to evaluate the patient. Okay, if they need urgent renal replacement, and remember, renal replacement simply, it's not just dialysis, so it includes dialysis, which can be hemodialysis or peritoneal dialysis, but it also includes things like hemofiltration or hemodiafiltration, okay, which we'll discuss under dialysis session. Okay, so you need to identify the patients that need very urgent renal replacement because it's very life threatening. Okay, so what are these indications that you need to place in to know who to refer? Okay, number 1, if the patient is in intractable pulmonary edema, you keep hammering them with the loop diuretics, they are not improving, you need to do emergency renal replacement. Okay, if the patient has hyperkalemia of greater than 6.5 or hyperkalemia associated with signs, whether it's cardiac abnormalities when you do an ECG, or hyperkalemia that is much more lower, above 5.5, but there is ongoing tissue loss, okay, whether it's through a form of rhabdomyolysis or potassium absorption problem if you're having GI bleeding, okay, those patients need emergency referral. Okay, signs of uremia, especially pericarditis or uremic encephalopathy, those are typically cardinal indications for doing urgent renal replacement. Okay, if you have severe intractable metabolic acidosis, okay, that is not improving on your medical treatment, you have. And finally, there are certain acute poisonings of drugs that will be indicated to get urgent renal replacement. Okay, so it's very, very useful to always make sure that you know. Okay, so otherwise, what are the general measures that you have to take in place if a patient has acute kidney injury? Number 1, as we are displaying there, okay, the moment the patient has nephrotoxic drugs, okay, and nephrotoxic drugs are like ACE inhibitor, your NSAIDs, okay, your ARBs, okay, and things like aminoglycosides, amphotericin, tenofovir, all those drugs, okay, you need to remove the nephrotoxic drugs. Okay, very, very important. And most importantly, also, you need to adjust the medication. A common one is like metformin. The moment your GFR is less than 30, it's indicated that if you can find a replacement for metformin, replace it. Okay, so those are some of the things that I'm showing there on the importance of adjusting medication that you can pause and read through. Okay, number 3, you need to make sure that the input and output you manage, you make sure, because you want to know what I'm pouring in is coming out, okay, or am I having anuria, or okay, so it's very important to monitor the input and output. Very, very, very important. Okay, then number 4, we have highlighted all the complications of acute kidney injury. One of the major ones is UNE derangements. Okay, you need to correct this. Okay, very, very important, or the patient won't get better. Okay, you need to optimize cardiac output, which we'll talk about in a few. Okay, we have already talked about patients that will need dialysis or renal replacement therapy. We have talked about the indication, and also very important, you have to treat the complications. Okay, treat the complications as I'm highlighting them there. Remember, whether you're having cardiorenal syndrome, uremic bleeding, okay, you're having life-threatening uremic symptoms like seizures or severe pericardial effusion. Okay, so these things you have to manage them. Okay, very, very important. Okay, and especially that's why every day you make sure you assess the patient if he's developing any uremic signs, because if he's developing things like pericarditis, pulmonary pericardial effusion, or encephalopathy, you need to do urgent renal replacement therapy. Okay, now let's talk about the fluids. Okay, so that you optimize your cardiac output. Okay, now for the fluids, what you need to know is that you have to avoid it in certain patients. The moment the patient has pulmonary edema, of course, you are not going to give the patient fluids. Okay, and especially if the patient is anuric. Okay, which means there's most likely an obstruction or severe renal disease there, and giving a patient whose anuric fluid is actually very dangerous because you fluid overload them. Okay, so you have to avoid fluids in this, giving fluids in these patients. Okay, now what's your choice of fluids? Actually, what we normally give is crystalloids. Okay, but also always consider fluids that stay in serum. Okay, fluids that stay in serum, whether it's blood, whether it's albumin. Okay, those are the fluids that you want to give, especially for pre-renal. Okay, otherwise crystalloids very good. Okay, fluids. Now fluids are important, right? But how do we give them? If the patient is clearly hypovolemic, okay, this is very important, you typically want to give them fluid, and this we see mainly in pre-renal failure. Okay, so you need, typically we administer 1 to 3 liters, okay, of crystalloid. Okay, preferably they should be buffered crystalloid. Okay, then you assess, okay, is the patient responsive? And responsive, you see it in the urine output increasement and in your improvement in your GFR. Okay, if there is persistent evidence of hypovolemia or inability to maintain fluid balance, we actually continue the maintenance isotonic fluid at around 75 mL per hour or greater, depending on the ongoing losses that you're having. Okay, now what happens if you are not so sure if the patient is hypovolemic or hypervolemic or isovolemic? You don't know. This is very common in patients which are older, okay, and patients with reduced effective arterial blood volume. Okay, so this patient, we actually give them a fluid challenge of maximum 1 liter. Okay, of an isotonic fluid. Now, based on the response to that, a decision will be made on how to continue. Okay, so that's very important. And finally, what if there is no response to the fluid that you give? Okay, patients who do not respond to the fluid, where you will likely see it in urine output increasing, or there will be a decrease in your serum creatinine, most likely do not have pre-renal failure. So you are thinking, does this patient have established acute tubular necrosis or other forms of intrinsic AKI, such as rapidly progressive glomerulonephritis, we see it all this time, or acute interstitial nephritis? Okay, so if you continue giving these volume expansers, okay, the fluid, okay, it will be very bad. Okay, so that's why they are discouraged. So if the patient has no response to fluid, you want to limit your fluids. You do not give them fluids. Okay, now it's important to know what is the role of diuretics in patients with AKI. Okay, actually, loop diuretic help relieve hypervolemia. Okay, hypervolemia among patients with AKI, but you have to make sure, remember, they are not anuric. Okay, and the most useful diuretic that we normally give is loop diuretics. Okay, they are typically much better than thiazide simply because they provide a greater natriuretic effect. Okay, that will be the only real reason why you would prefer them. Okay, now ending off the management. Okay, what you need to highlight in your brain is that management also differs on which type of acute kidney injury you are dealing with. Okay, remember in pre-renal failure, you are typically dealing with hypovolemia. Okay, and especially drugs like AC inhibitor, diuretics, or NSAIDs are typically implicated, so you definitely want to stop those. Okay, but other things that you need to do is to optimize the volume status. Okay, correct the underlying cause. If the patient was bleeding, if the patient is in heart failure, a patient has sepsis, whatever, correct that cause. Okay, and you optimize the volume status absolutely, and you improve the cardiac performance using fluids. Okay, that will normally stay in the plasma compartment as we have highlighted. Okay, and of course you want to hold your drugs. Especially these 3 drugs are typically implicated in pre-renal failure. Okay, moving on to intrinsic. Okay, remember in intrinsic you want to address the reversible renal causes. Okay, which means you discontinue the nephrotopic drugs, you treat the infection, and you optimize the electrolytes. Okay, remember to correct your ECF volume. Okay, you typically give supportive care, consider corticosteroid or immunosuppressive therapy, especially in treatment of acute tubular necrosis. It's typically supportive. Okay, if oliguric, a trial of furosemide may be of help. Okay, as we have mentioned. Okay, so that's very useful to consider. And finally, for your post-renal, you consider obstruction. Okay, whether it's structural in the form of stones or strictures, or it's functional in the form of neuropathy. Okay, so what you want to do is to correct that obstruction. Okay, so it's very, very important. We typically put up a Foley's catheter to insert it, or you do an indwelling bladder catheter, or a nephrostomy or stenting. Basically, these patients usually need a urological consultation, okay, especially if there's a serious obstruction. Okay, then finally, I want to talk about two things. Okay, the prognosis. What is the prognosis of a patient with acute kidney injury? In most of the cases, 80% they will actually recover. Okay, that's very optimistic. Okay, but there is a high risk of morbidity and mortality, and especially multi-organ failure, especially in old people. Okay, so you should look out, or patients with comorbidities. Okay, very, very, very high mortality here. Okay, so you want to make sure these patients that you take care of very well. Okay, and finally, the last thing I want to highlight is the cause of death. What would be the cause of death in a patient? Okay, most, okay, about 75% will actually be due to an infection. Okay, remember, one of the cardinal complications of acute kidney injury is a risk of infection. Okay, and of course, if you get the infection, it will obviously be followed by a cardiorespiratory complication. Okay, so please screen your patients for infection and make sure you do not get an infection in this patient, because it really, really contribute to serious mortality. I thank you.